All right, so now we're going to look at leukemia treatments and their therapies. Okay, so when looking at leukemia treatments and therapies, we're going to look at acute leukemia. The induction phase is intense and aggressive. It usually is a combination of different chemotherapy agents. They usually are in the hospital a prolonged period of time, secondary to their neutropenia. Then there is the consolidation phase. This treatment is in early remission and the intent is cure. So this is the consolidation phase of treatment. This is during early remission and the intent is cure. Okay, maintenance therapy may be for months or years, and the purpose of maintenance is remission. But remember, not all leukemias respond to maintenance therapy, but it's the consolidation therapy. If it's in early remission and the intent is for cure. Chronic leukemia, they look at chemotherapy and they usually will look at stem cell transplants, may offer a cure for these patients. We've already looked at the bone marrow procedure for a biopsy. The procedure for obtaining the bone marrow for a bone marrow transplant is very similar. Okay, these patients, their standard treatment in temporary remission after the induction therapy. It's prior to transplant. The total body irrigation to purge the bone marrow of the leukemic cells. So before the transplant, they radiate the body to get rid of as many of the cells as possible. So these patients are very neutropenic. And then, so they're trying to get rid of all the leukemia cells before giving back the bone marrow in the transplant. Okay. And quite frankly, the process of the patient actually getting the transplant is very similar to a normal infusion. The side effects can be fever, hypertension, and hematuria. Remember, the big thing when doing a bone marrow transplant is that you do not use a blood filter because the bone marrow can kind of collect to the sides. Okay, make sure that you look at the action alert on page 824. It talks again about not using a blood filter. Okay, that's very important. All right, guys, the engraftment period, this is the successful take of the transplanted cells into the patient's own bone marrow. The peripheral blood stem cells are 14 days. The bone marrow transplantation is 21 days. Okay, that's when it's considered engrafted. Now, I know I've gone through a lot of this kind of on the quickly side, but this slide is important because this is when the patient is in their post-transplantation recovery. The patient does not have immunity until the transfusion grows cells and engraft. Failure to engraft occurs when the donated stem cells fail to grow and function in the bone marrow. Okay? The graft versus host disease. Graft versus host disease is when the graft is actually trying to attack the host tissue and cells. Okay, so both of those are signs of rejection. So how do we prevent complications in these patients? Well, we're going to look at chart 4010 to see ways that we can prevent infection. We're going to make sure that we're taking care of their fatigue and conserving energy. That's in chart 40-8. We're going to talk about their home care. We're going to talk about preventing infection in chart 40-10. We're going to look at ways to prevent bleeding in 40-11. Okay. Some of these are quite simple. We're going to start with the infection, which is chart 4010. Of course, avoid crowds. If possible, bathe daily. Use a clean toothbrush either daily or clean your toothbrush daily by running water, running it through the dishwasher or rinsing it with laundry soap. That just sounds gross. I think I would just get a new toothbrush. Sorry, squirrel. Wash dishes between uses with hot sudsy water. Do not drink water that has been standing longer than 15 minutes. There's some very interesting, do not feed pets raw or uncooked meat. Take your temperature twice a day. So look at some of these preventions for infection because they're pretty intense. They're more than just your usual prevention of infection because remember, these patients are extremely immunocompromised. And remember, your patient with leukemia can also is at risk for bleeding. So you want to have them use an electric shaver. That's including ladies on their legs, a soft bristled toothbrush. You have to wonder if you take a soft bristled toothbrush and then run it through the dishwasher, is it going to last? But anyway, you want to make sure that they don't have any dental work done until it's okayed by their oncologist. You want to make sure that they're not participating in contact sports. Just all of those things that are risks for bleeding. But those are important and they're on page 827. We've talked about that failure to engraft, that graft versus host disease. It's when the graft is actually fighting against the host and the host cells. You want to try to minimize that injury. You want to reduce fatigue and conserve energy. That's on chart 40-8. Okay. Alrighty then. Multiple myeloma really can't be discussed in one slide, but we're going to because I just want to do some touching bases on it. It's a white blood cell cancer involving the overgrowth of the beta lymphocyte called the plasma cell, okay? The cause is unknown. It's mostly over the age of 65. Patients usually first notice fatigue or that they have easy bruising or they have bone pain. As the disease progresses, they'll have bone fractures. They'll have some problems with hypertension, hypercalcemia. There is no treatment. It is incurable. Pain management is your number one goal with these patients. Okay? These backing it up a little bit, the plasma cells secrete antibodies when they are cancerous, and they produce excessive antibodies, increasing the serum protein levels and clogging blood vessels in the organs. Without treatment, leads to bone destruction, bleeding problems, kidney failure, and death. And unfortunately, it's not curable. So sometimes the treatment isn't worth the because you're only doing it for palliative care a lot of times, and a lot of times the chemo makes them almost as sick as the multiple myeloma is. So sometimes patients choose just to go into hospice care once their multiple myeloma gets bad. Okay. All right. Now I know Ms. Stone did an excellent job of teaching about blood transfusions in lab. I know some of you have not been to lab yet, so I do want to spend just a short, a little bit of time on transfusion therapy, okay? Basically, because that way we can test on it if we do look at it today. So I do want us to take a few short minutes to look at transfusion therapy, starting on page 832, okay? When you're doing a transfusion, with transfusion therapy, you want to make sure that you're using best practice. And the transfusion therapy best practice chart on 40-12 does a beautiful job on the whys and why you do things a certain way. Okay, so I want you to make sure you look at those. I want you to look at why you're doing the blood checks, why you're making sure you're staying with your patient, how much blood that is transfused can be a sign of how much blood is usually transfused before you see a bad reaction. So I want you to make sure you look at all that. I want you to look at indications for blood therapy. More so, not so much that like the exact volume numbers on your packed red blood cells, but what I do want you to do is in table 40-6, I want you to look at the blood component, the infusion times, and the indications for. Again, for table 46 or 40-6, you look at the blood component, like red blood cells, packed red blood cells. They're infused over 2 to 4 hours. It's given for anemia. Platelets are given 15 to 30 minutes. It's given for thrombocytopenia. It's given for patients who are actively bleeding. Fresh frozen plasma, it's given for a plasma coagulation with deficiency in plasma coagulation factors, given a lot of times when somebody's been bleeding a long time. So I want you to be able to look at those and look at the indications for why you're giving that certain type of blood, okay? It's very important really just to know that as you enter into practice, to know not only why you're giving, how to give the blood, but what is the reasoning your patient is requiring that transfusion. And you know how I like my JEROs. So I want you to look at chart 40-13 on page 834. It talks about the older adult receiving a transfusion. It talks about how they may need a longer period of time, that try to use blood that is less than a week older with older people. You have to watch out for fluid volume overload. You have to administer the blood slowly, taking 2 to 4 hours for each unit. I would go more with at least 3 to 4, but we'll go with what's in the book. And make sure that you do read through that, because it is different when dealing with a patient who is, older, okay? Make sure you read through those action alerts as well. They've got some great information about giving blood. Giving blood products is very serious and is very dangerous, but is life-saving. Blood transfusion, assess your vital signs immediately prior to starting your transfusion. I won't test you on this, but take it from the old nurse. Make sure that you flush your IV before you send for your blood. Again, flush your IV line before you send for your blood. So make sure you've got a nice, happy, patent IV before you send for your blood, okay? Because you only have 20 minutes or whatever the policy is at the facility that you're at to hang your blood once it gets on the unit, okay? All right, so we've already talked about the older patients. We've talked about starting the transfusion slowly according to whatever the policy is at your facility. My facility, it's you start it at 100. You stay with the patient for the first 15 to 30 minutes, okay? So you want to make sure that you're doing that as well. Lastly, a blood reaction will usually occur within the first 50 milliliters of blood, okay? Any severe reaction usually occurs within the first 50 milliliters. They'll have chills, shortness of breath, itching. A lot of times they complain of back pain. You stop the transfusion and remove the blood tubing. You notify the response team if needed, but don't flush the tubing that has the old blood in it, okay? And then you run the normal saline in a clean line, all right? And you send both the blood and the tubing back to lab. But people will make the mistake of panicking and wanting to start that saline so quickly that they're not realizing that they're, infusing another, 20 milliliters of this blood that's causing the reaction to their patient. So you want to make sure you don't do that. All right. As far as blood transfusion goes, if it's not on one of the charts that I mentioned, or it's not in the PowerPoint, it won't be on your test, okay? But blood transfusions are very important, and we need to make sure that we're doing them correctly. That's it, guys. Bye.